Welcome again, everyone. Greetings. This webinar is brought to you by Yetena Weg and the Ethiopian Medical Association, specifically the Ethiopian Medical Journal. Today's research topic is research ethics, and our guest speaker is Prof. Wendemagegn Enbiale. Before we proceed to the today's presentation, I'll be giving brief introduction about Yetena Weg and the Ethiopian Medical Journal. Yetena Weg is registered in Pennsylvania, USA as a nonprofit, and it's entirely run by a group of volunteers. As of now, we have 70 active volunteer members across 5 different countries, and we're still increasing in number of volunteers. There are 4 major areas of engagement, mentorship and skills sharing, and finally, medical education. So these society and community engagements you can see are volunteer activities. They are prepared entirely by our team, and we hold different campaigns like blood drive campaigns and book donations and so forth, and also free health screening campaigns. The other major area of engagement for Yetena Weg is the Yetena Weg Health article writing competition, which is done in collaboration with the Ethiopian Medical Students Association. We host these competitions to foster the writing skills and creativity of medical students, and we award the winners accordingly. So you can see the winners in this picture. The other major area of engagement for Yetena Weg is the Yetena Weg Research Fellowship, and it was launched on March 14th in collaboration with Addis Ababa University of 3 departments, oncology, radiology, and internal medicine, and research grants were given for up to 4 winners, and mentorship was provided for 10 of the winners. So as continuation of this initiative, it continued with St. Paul's Hospital Millennium Medical College, and this time it involved medical students, and again, the research grant will be awarded for 4 winners. So these were the winners. The other major branch of Yetena Weg is the continuous medical education branch, which also hosted today's webinar. So the webinars are freely accessible, and Yetena Weg collaborates with different societies and associations to prepare these webinars, inviting experts on different topics. So we collaborate with the Ethiopian Medical Association, the Ethiopian Society of Cardiac Professionals, and Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. So far, as of now, we have conducted around 38 webinars this year, and the average attendees range from 150 to 200. And you can find our previous CMEs on our YouTube channel, and you'll find the link for the social media. So for the section or the chat box, and at the end of the webinar, the guest speaker will address your questions accordingly. So to get the CU certificates, you have to fulfill these 3 steps. The first one is attend the whole session virtually and fill the Google form, which will be shared at the end of the webinar. And finally, get 50% or more on the post-webinar quiz, which will be shared at the end of the webinar. Thank you so much. Now I'll be saying a few things about Ethiopian Medical Journal. The Ethiopian Medical Journal is the oldest and pioneer in Ethiopian scientific writing history, and it is a research wing of the Ethiopian Medical Association. It is an open format, web-based health science journal. So we encourage authors to send their scientific works to the Ethiopian Medical Journal. Without further ado, I will introduce our guest speaker today, Professor Wendemagegn Enbiale. Professor Wendemagegn is a professor of dermatovenerology at Bahar Dar University. He brings over 20 years of experience and expertise to his field. As a medical doctor holding a PhD in global health and dermatology, his career encompasses a wide range of clinical, academic, and research and administrative responsibilities. His management, community-based research, operational research, and clinical trials. His contributions extend to international platforms where he serves as a member of the WHO Strategic and Technical Advisory Group for Neglected Tropical Diseases, NTDs. He also holds position as the Vice Chair of the International Alliance for Global Health Dermatology, GLODER, and Vice Chair of the NTD Advisory Board of the Ministry of Health of Ethiopia. He has been teaching medical ethics for both under and postgraduate students for the last 14 years. He's currently affiliated, his current affiliation is he's serving as adjunct professor in Bahar Dar University and collaborative research and training center for neglected fellow of Ethiopian Academy of Sciences. We are very honored to have Prof. Wendemagegn. He actually also serves as editorial board member to the Ethiopian Medical Journal. Prof, the floor is yours.
I'll be just jumping directly to my presentation, and the topic assigned to me is research ethics. Especially I'll be focusing on clinical research ethics and contextualizing to the Ethiopian scenario. I'll be starting with ethics in clinical research, and just as a background, and go some lessons from history and why we have now some of those ethical guidelines and from where they have been derived, and the existing guidelines, especially internationally and nationally. And I'll use some published ethical frameworks to go through some of the principles, and then finalize with Ethiopian situations. So when we think of especially clinical research ethics, I would like to bring you to some, the most important question is first, what makes a research really ethical? From here, you see two articles. One is from Ethiopia, and assessment of HIV/AIDS related risk among men having sex with men in Addis Ababa, which has been published in 2009. And this research has evaluated or seen around 40 MSM in Addis Ababa, and the conclusion of this research is that men have sex with men among a segment of Addis Ababa population, and the proportion of involved is negligible. They are exposed for HIV/AIDS risk. It's therefore high time that the issue be openly discussed in the context of current effort to control the HIV epidemics. Diving deep into the finding, it has also stated how many percent of the population are certain religious group, and so on. And the other journal is a journal I used from the New England Journal. You can see that this study is randomized clinical trial, which has included pregnant women to test their thyroxine and thyrotropin level, and then for those and the control and study group, and for those who are positive from the study group, they gave them the medication, and the end result of the study is to see an IQ level of the kids after 3 years. So the most important thing is to say those things are ethical and ethical. The first thing is, how do we know to say those research are ethical? So the whole concept of the presentation is going to actually move around this, just to analyze some of those nitty-gritty factors to see how we can determine a research is ethical or unethical or controversial, actually. So when we think of ethics in clinical research in general, the goal of clinical research in a nutshell is to generate a useful knowledge about human health and illness and the way to prevent, diagnose, and treat disease. This is the most important factor. And so whenever we think of ethics, it has to really accommodate those systems. The goal is not to benefit primarily to the individual who participated, but the goal is just usually looking into the broad picture to the community or to the society. So most of the time we say that actually clinical research has a utilitarian functions. So people are the means to developing useful knowledge and thus at risk of exploitation. So whenever, if at the end of the clinical research, especially phase 3, phase 4 trials, or randomized clinical trials, we use human beings. And the most important thing is, are we really using them to generate scientific evidence which can benefit for human beings, or are we using them as a guinea pig? So to balance this, just there is the balance between, because whenever we think of a research, the benefit has to outweigh the risk, and that means the promote benefits to society and the future patients, and to do so, and to protect and reassure that the welfare of the participants are the most important thing. So ethical researches, the lesson learned from the history are just there. Before the 1950s, there was really few rules. This was the time physicians used to execute what we call it a paternalistic medicine. And even the research used to be actually like a paternalistic clinical research. That means physicians know everything, and whatever they're doing it is that for the good of the patient and the community. So it was just going, most of the clinical practice and the research was going through this, the trust on physician, the virtue on physician. And following the 1950s, the crisis, especially the turning point was the Second World War. There was red flags, especially from the Nazi concentration camp and the Germans, and also what the American has done. So following that, the people start to scrutinize, actually, not only clinical research, even clinical medicine. And there was a utilitarian era emphasized on the benefit of the society, inclusion that was before the 1950s, but later on, examination of the scope and the limitation of those, the paternality medicine brought additional legislations and restriction in those clinical researches. And rule and regulation protecting human subjects has come to the front, and participation research used to be considered also later on as benefits. But the turning point, to just come up to the turning point, usually how we have started or how we have reached to this point, especially this later on, we're going to go through these massive guidelines or code of ethics. As I have said, it's before the 1950s, it was the paternality medicine and paternality research. Physicians being considered as, or researchers being considered as virtuous. That means they do whatever they do for the good of humanity. But it was actually known even before the Nuremberg trial, which usually people consider the turning point. The Americans have been actually implementing unethical things. For example, implementing the eugenic endorsement of doctors. The eugenics movement was those people who think that a good gene or creating a proper society. And the eugenic movement in US was being endorsed as early as 1990s, 1907 actually, and it is allowing for compulsory sterilization of the socially inadequate people. In the US, those laws actually in the next 20, 30 years, they have started in one state and they have encompassed more than 23, 26 states. And practically, without a consent of the individual, they have been sterilizing people, and in the name of either if they are criminals, mentally disabled, or have an alcohol problem, and other issues. And so between the 1907 and 1939, more than 30,000 people in 29 states were sterilized. The Germans were late, actually, but they have really understood the idea, and they just came back after 26 years. In 1933, the German has passed first this sterilization law. But the Germans were really fast, and they used a lot of research to get the most efficient sterilization method. They used radiology technique, injection of cauterization, and injection of substances into the uterus and so on to sterilize the people whom they think are incompetent or socially inadequate. And in German, the law mandated the forced sterilization of certain individuals with physical and mental disability or mental illnesses. But this was judged by certain courts, and the courts has actually even physicians, anthropologists, sociologists, and so on. And the disability ranges from medical disability, congenital illnesses like Huntington disease, schizophrenia, and even drunkenness, and stealing, and so on. These are considered as socially inadequate people. And the Germans has accelerated this in 1940s, following using the Jew, and the forced sterilization actually in just less than 10 years, they have managed to sterilize around 400,000 people. And some of them, actually, some of the women has died during even the experiments first. So, and then you have the Nazi human experimentation, which I'm not going to go in detail. But the most important thing is during the Nazi human experimentation, physicians were being used to create or just for torture and also for political purpose. And the main goal of this experimentation was to create an Aryan master race. That was the sterilization also was part of that. And scientific pursuit designing to yield information applicable to the military and political goal, and advancing personal goal agendas for the researchers also at that time. And there is a very interesting, actually, book about that, and which is written by a woman who has been the court secretary in the 1946 to the 47, 49 during the Nuremberg trial, Vivian Spitz, doctor's head. And those experiments ranges, this is the picture from up left is Joseph Mengele. He was the lead physician, actually, the lead researcher. The research list is a lot. I'll leave most of it for reading, actually, some of the examples. And the most horrific examples are like, for example, the altitude tests. The Jew or the Roman were being taken with the plane up to 60,000 feet and without an oxygen. And there is the physicians with his oxygen and with his mask, monitoring at what time did they stop to breathe, at what time they have died. And then when they go down, even if they haven't died, they will kill them to see how they have survived and do the autopsy. The same test was done to look for how long a German soldier can survive from the same height German pilot can survive if they fell down. So they used to throw the Jew from those heights and to see what type of bone are they breaking and at what time do they die, and so throw those people in the sea and to see for how long can they survive with seawater. So these are just, and so actually just in 1946, July 1947, finally there was courts, and 21 of the health workers, most of them were physicians, 11 was sentenced by days, and but the most important story after the Nuremberg trial was the world stopped to trust physicians. That's the most important point I'll say. And the funny story was the Nuremberg trial was tried by the Americans, and the Germans' defense was actually the German physician. You are doing the same thing in US. Why are you blaming us for this? But that Nuremberg trial has come with 10 pointers as a derivative of the ethical principles we are using today. So the most important thing which has come from this code of ethics is the voluntary consent. We'll go later on. And then anyone who has to participate in the research has to voluntarily consent. Later on with the Helsinki Declaration, they have added informed voluntary consent. And the second is there has to be anticipated scientific benefit from the research. And any research before it goes to the human trial, it has to first pass through the animal experiment, which recently this has been also revised. Avoid suffering, that is no harm, no intentional death or disability, benefit outweighing the risk, protection from harm, qualified investigators, most important thing, and subject free to stop at any time when the participant wish to stop. They have the mandate to stop. Investigator will stop if harm. So this is, as I have said, the blueprint actually for the current both ethical principles for both clinical practice and research we are using currently. But the Nuremberg trial and the 10 Code of Ethics were actually designed in general just to protect the population from any form of research. But the World Medical Association in 1964 in Helsinki, actually, they reformed or reviewed the Nuremberg trial Code of Ethics and came up with those 8 principle of Declaration of Helsinki. And the first is protecting patient health. Knowledge cannot. The last time it was revised was in 2013. And this is because every time there is an advance in medicine, when there was a challenge in ethics, it was really difficult. The big problem with medical ethics and also research ethics is it's not really dark and white. Sometimes it's really difficult to say something is ethical and unethical. And there were new things we have learned. And the science was also changed. And there was a new development. And as a result, those guidelines and principles has to be revised. And the other most important source of our current ethical guideline is to see the natural history of syphilis. So they involved 399 patients and 200 control, in total 600 African American. And most every month to 6 months, they were taking blood, spinal tap, and so on. And whenever they come to the hospital, they give them free meal, and they told them that they are being treated for their syphilis. And they have never, or for their blood, but they have never been told they have syphilis or what they are doing on them. And so they were enrolled without consent. And the study, even after the 1940s, when penicillin has come to the market, there was a cure for syphilis in 1942. Actually, during the Second World War, the American pharmaceutical company Merck has profited more than 40 million USD from penicillin from the war. But those patients were denied to be given penicillin. Every hospital in the surrounding was told not to give them medicine. And there were some whistleblowers who has, and every 5 years, actually, the study result was being reported. Patients were being followed, and the complication, all the syphilis, from primary syphilis to tertiary syphilis, the course was being recorded. And some of those people, they gave birth. They gave birth for syphilitic children. And some whistleblowers brought the issue to the media. And in 1972, the New York Times and Bloomberg and so on has really published a lot about this study. And at that time, the study was stopped. The study was stopped, actually. And then, during this time, there were only from the 600 participants, there were only. So the study was very much successful, and there was the dropout rate was less than 1%. And the reason behind was they used a very trusted nurse to recruit those patients. And they were promised for hot meal, paid funeral, and so it was no secret. For every 5 years they were published. From this study, from this crisis, actually, the legacy of the Tuskegee study has brought the US congressional investigation of the study, and then the Belmont report was published. The Belmont report is the report with the 3 main ethical principles: respect for person, that means autonomy, beneficence and maleficence, and the justice. And so the existing guideline from all this, from the wrong the American has done, the Tuskegee trial, the German, and so on, the world started to develop actually both international, even regional and national guidelines. So from the Nuremberg Code, we have the Declaration of Helsinki, the Belmont report, then the International Ethical Guideline for Health-Related Research from WHO and CIOMS, which has been revised to the 1916. And also we have this international, the harmonization, good clinical practice scientific guideline, which is being used by the American, the Europeans and Japanese. And then from locally, from Ethiopia, we have the National Research Ethics Review Guideline, which is now the 5th edition, and Clinical Trial Authorization Guideline, of defined as the standard. It's an international ethical and scientific quality standard for designing, conducting, and well-being of trial subjects are protected, consistent with the principles that have their origin in the Declaration of Helsinki, and that the clinical trial data are. So, in summary, each actually country and those guidelines has some ethical frameworks. And I'm just taking those 7 ethical frameworks to say a research is ethical or not ethical. We go through those 7 ethical frameworks. The first is valuable scientific questions, valid scientific methodology, fair subject selection, favorable risk benefits, independent review, informed consent, and respect for enrolled subjects. I'll go one by one and for some. When we say valuable scientific question, the first thing is whenever we do a study, the most important thing is it has to generate some new knowledge and understanding about human health or illness. We don't do research only for scientific purpose. And socially or clinically or scientifically has to be useful. It has to have useful question. I remember once the former Prime Minister Meles Zenawi commenting on some research saying that Ethiopia researchers የዝዋይ አሳ ከሐዋሳ አሳ አይኑ ይተልቃል የሚል ጥናት ነው የሚሰሩት አይነት ነገር ነው። It must not be like that. Whether the Prime Minister's comment is credible, I'm not sure, but this is the most important thing is it has to have scientific and social value. When we say social value, it just actually, it depends from country to the country. The social value. And promotes benefit to the society, minimize exploitation, justify asking individuals to accept risk or not. I'll bring this research actually back again to express the social value of research. Assessment of HIV/AIDS related risk among men having sex with men in Addis Ababa, Ethiopia. Well, if it was face-to-face presentation, I'll ask you, what do you think about this? But the most important thing is, well, this research is ethical if you do it in the West. But in Ethiopia, it was unethical. It was unethical. But the most important thing you have to know is this research was supervised, done by a student, but supervised by one of the most senior researcher. The most senior researcher. ይሄ በጣም ኢትዮጵያ ውስጥ አንድ አቧራ ካስነሱት ሪሰርቾች ውስጥ ነው። በጣም አቧራ ካስነሱት because at that time it was presented to Ethiopian Public Health Association meeting and ወዲያውኑ Global Health has come with funding to the Ministry of Health Ethiopia for HIV, protecting men who have sex with men. And the issue is, usually ethics are there to protect the norm of the society. In the Ethiopian context, the ministry said, we don't have those people. And the other defect on the most important thing on this research is it has put some group, like certain religious group are more exposed to certain. Is that important? And there are also valid scientific methodology is the other thing. Ethical clinical research should be designed in methodology, rigorous manners. The design, the method, statistical power that will yield valid, reliable, generable, and interpretable data, and that's feasible. And this is one of the research actually we have been, we have entertained its ethical value in the Ethiopian Medical Journal. And it was, if I'm not mistaken, it was 2 years back or something, a legislation of abortion and maternal mortality in Ethiopia. It was by one of the Westerners. And practically the conclusion is that የሚለው ምንድን ነው? የኢትዮጵያ የአቦርሽን ህግ maternal mortality አልቀነሰም የሚል ነው conclusion. But when we went into detail, ይሄን study actually gynecology, oncology ማስተምራቸው just course የምሰጣቸውም ልጆች evaluate እንዲያደርጉት አድርጌ ነበረ እና the most important thing, the research he has used or the quote he has used were wrong. The method he has used was wrong. And finally, actually, we found out actually this is a guy from UK who has his own interests on against abortion in general from a certain group, philosophically. So he was philosophically, this was with vested interests, not with scientific facts, who has published this study, but unfortunately, it has passed through the Ethiopian Medical Journal and published later on retracts ይደረግ የሚል recommendation ነበር። And fair subject selection, the subjects who are going to be included in the study, it's very much important. In Ethiopian law, there are certain vulnerable group which has to be protected. But the most important thing is when you are thinking of a research, it has to include the diverse community which will be affected by the disease. Before the 90s, just to give you a simple example, before the 1950s, actually, most of the research was being done in men and only on men. And the drug which has been developed were mostly for men. And currently, you may get from the researches and actually from some campaign, cardiac drug which has been developed for men, being given for women with a different hormonal and other status, and which has actually increased the risk factor of the mortality in females and so on. So any research, the favorable risk and benefit, we have already discussed about those things. The most important thing is independent review board. There has to be any research. When after we write the protocol, it has to pass. Ethical requirement has to be fulfilled. The check investigator bias and conflict to assure the public that researcher is not exploiting individuals or a group. It has to pass through the RB or the internal review board or the ethical committee. And usually the RBs, more or less, they have those documents which look into the risk is minimized and justified, subject will be selected and treated fairly, informed consent, there is informed consent. So, but the challenge for the RBs in both actually Ethiopia and the other setting is usually the RBs are voluntary workers. So sometimes for the researcher, it's inconvenient. For example, just typically in our setting, the national RB, I remember the የመጀመሪያውን COVID outbreak እንደተነሳ ፓንደሚኩ እንደተነሳ we submitted a document, an international cross multiple sites research, and we got the ethical approval after 2 years or after a year and a half. And one of our research on in STH, it has to take 3 years for approval. So sometimes just think of the COVID study. We got the ethical approval after the COVID pandemic was being subsided. So our participant rate was really dropping. So the informed consent is the other issue in both. This is covered in both guidelines. The goal of informed consent is to ensure that individuals have the opportunity to decide whether they want to participate in research or continue participation and whether it is compatible with their goal, value, and interest. And the most important about informed consent is at any time, the participant have the right also to withdraw. So in informed consent, one thing which is really challenging for most of the researchers is that we have to disclose everything. And that is in understandable language. In understandable language, we have to give them the objective of the study, the risk, benefit, and the alternative of the study, and assessing, understanding, and seeking their voluntary agreement. And we have to really assess also whether they have understood what we mean. The challenge is some of the scientific words are difficult to interpret. and especially for our society in our own language. So I will give you some example on whether the thing is, when we say research and ethics, sometimes it will be contextualized based on the countries, even though the blueprint of ethical guideline internationally are more or less the same. It's usually based from the human right, from the 1950s human right. But depending on the country also, you may have a different contextualization, like the research I have shown you about the HIV men with having sex with men in Ethiopia. And this is a study in Malawi we use, and this is just in 2010. Malawi had 25,000 TB cases, and 30% were co-infected with HIV. So to reduce loss to follow-up, the TB HIV program traced such patients at home using the Ministry of Health vehicles. So the study is an operational research team deciding to report on proportion and reasons of loss to follow up as part of the record review. Now, what do you think is the ethical consideration which come to your mind here? And how could the researcher address them? And in short, the most important thing is when you go to home for those patients with Ministry of Health vehicle, that means at 2010, that means you are telling the people around these are HIV patients. So ethically, you are not protecting the privacy of your patients. There is another study which was important actually come to our attention. In Libya, alcohol has been illegal to sell or consume since 1969, but there is a black market with smuggled and home distilled alcohol. So the study in 2013, MSF outer working in conflict zone of Libya gathered routine data of 1,000 cases of methanol toxicity from 3 hospitals. Methanol was the alcohol they were drinking, actually. And all individual patient identifiers were removed, and ethics approval was requested for record review. And actually, they at that time, the ethical review board was questioning this research ethical. And the most important thing here is even after removing all the identifying factor here, Libya was, in 2030 was being havocked by, well, it's a Sharia law. So if you identify the area, either the IS or the Sharia court is going to execute all those people, or going to take a measure in this place because drinking is prohibited. We have to really, even de-identifying people doesn't make it ethical. And this is another study from Afghanistan. An American student, she went to Afghanistan. She decided to go there and to look into maternal mortality is high and where she wants to help. She wants to see what can she do. And then she opted to study a access to condom among young women as pregnancy control in Kabul, Afghanistan, using a household survey. So I think you know already now what's the problem here. So the situation in Ethiopia. Most medical research that have been conducted in Ethiopia are done without actually the knowledge or consent of whom the research was carried out. Culture is progressively changing now towards the issue, and many ARBs have been constructed in many government and some NGO in Ethiopia. The 3 national agencies, bodies, and their function is just, there is a National Ethical Review Committee, which usually looks into researches, biomedical researches, especially collaborating with another country, if there is an invasive procedure, and if there is material transfer out of the country. Ethiopian Food Drug Regulatory Authority, usually it's not really an ethical review committee, but it look into if it is a study which uses medicine or any procedure or intervention, you need the approval from the Drug Regulatory Authority, and you have also the Ethiopian Biodiversity Institute, usually, which looks specifically material transfer agreements and international collaboration researches. But each university, and most of the university, they have their own internal review boards, and especially regional researches who doesn't use serious invasive procedures and doesn't have international collaboration can be approved in those institutions. Most important thing I would like to say here is Ethiopia is an excellent pool for medical research due to large population size, the diversity of population composition, the high prevalence of infectious and NCDs. So every health organization directly or indirectly involved in medical research should have an IRB, and there is some special protection in our guideline. But the challenges are currently there is multi-sites and multinational studies are coming. And this is one of our study actually during the COVID time. We were collaborating with, the study was being implemented in 26 institutions, in 13 countries. So it was very much competitive. And the issue is, if you look, we have lost a lot of money actually compared to Kenya, because in Kenya, the ethical approval was within 3 months. In my country, the ethical approval usually takes a year and above, minimally a year. So because the study was supposed to be done urgently, the study has to shift to Kenya. And research using database or samples, genomic data and sharing, these are some of the critical issues. And research administration is very challenging, and the security issue has also brought some problems, especially currently with the field studies. And finally, the questions behind research is honest reporting of the results and justice of research, especially. And as individual, whenever we see a problem, we have to be whistleblowers or we have to report. And thank you. I think that's what I have. Thank you.
Thank you so much, Prof. It was a very insightful presentation. I think we can pass to the Q&A discussion time. Dr. Tadel, you can facilitate.
Okay, thank you very much, Professor. That was a quite engaging and interesting session we've had. So we'll go over the Q&A together. Can you see my screen?
Yes.
Okay, so the first question is, does case reports need IRB evaluation?
My answer is directly yes, especially because case reports are reports about patients, about individuals. The first thing is they need the individual approval. And usually every case actually, it needs IRB to go to IRB, but the IRB, based on the guideline, they can give you waivers. That means they can exempt it. But every research has to go to IRB, especially case reports. Usually they contain sensitive materials about individual patients. And the IRB has to make sure that the patient right is protected and it's anonymized and so on. So that's the most, and it has to, they have to see the social value and scientific importance and the consent. So it has to go, anything which needs consent and biological, which needs a human involvement, has to go to the IRB. But the IRB doesn't mean that for everything you need the IRB approval. IRB waiver is also a paper which is needed actually for publication. Thank you.
Okay, thank you very much. The second question reads, how can we balance the sample size and quality of the research with participant rights if a study subject wants to quit their participation on the research?
Well, I think the most important thing when we see the research, especially the usefulness of a research at the end of the day, is methodologically you have to do it right. And that's the sample size, and that is the power. And this is just the statistician work, which is has to be calculated. But I think your other question is, right?
So I can read the question. If the study subject wants to quit their participation on the research.
Yeah, there is no really, you don't even ask them a reason. There is no even asking for a reason. If they want to quit, that's their right. It's very much challenging. In one of our study, actually remember that this is, again, the COVID study. We did 3 clinical trials in COVID, and we have a lot of dropouts. And it's very much expensive study, a very much expensive study. And since we have started also the study when the COVID case was dropping, we're really looking, and it was competitive, 26 institutions throughout Africa. So the number of people you recruit, it matters, both in scientific, also monitoring. So for us, it was very much challenging. But at the end of the day, if the patient says that I don't want to participate, they have the right to quit from the study and get also the proper advice and treatments. Thank you.
Okay, thank you very much. The third question reads, while disclosing the study to participants, what is the recommendation for those who are illiterate, and how deep should we tell them about the subject matter?
Yeah, the thing is, there is no, in a study, we call in clinical, actually in clinical practice, we have to consider that every patient has the right to know everything. This is culturally very difficult sometimes for us in Ethiopia, but, and also we may think that, oh, the patient doesn't know. But if he doesn't know, the first thing is you have to try to explain, and you have to use, if there is another person, you have to get the help, and you have to ask the patient if he understands. If he doesn't understand the participant, he will not be part of the study. So there is no way out. This goes also not only in clinical research, actually, it goes in the clinical care also. You have to explain the procedure you are going to the patients with all risk and benefits, and the decision will be for the patient.
Okay, thank you very much. The fourth question reads, if a researcher suspects that their study design might inadvertently disadvantage a vulnerable group, how should they address it?
They have to stop. That's at any time, there are two ways. Either what will happen is, just I'll give you case examples. The AstraZeneca study. If you remember the AstraZeneca study, at one time, after recruiting like 10,000 people, a patient has died from embolism. And what happened? The study has to stop. There was 2 weeks investigation by the independent review board and found out that this is not really related to the vaccine, and they continued the study. But if your study or your whatever trial treatment is harming an individual, immediately the study has stopped. And also, after you start the study, if one of the drugs you started or the trial drug has a better, much better outcome from the early, you have to stop the study and give every patient the trial drug. That means it goes in both sides. It's harming, you have to stop. it's benefiting just from the outset and making a good result, the other patient has a right to receive that.
Okay, thank you very much. The previous question reads, with advancements in AI and data science, how do you ensure ethical use of patient data in research?
That's a very challenging time. Currently, I work on AI, just trying to teach the machine learning on dermatologic data, especially on dark skin individuals, to increase the diversity of. And the most important thing we have found here is actually how to ensure the privacy of those data and to get access for those data. And there is a lot of guidelines to anonymize those data and just to secure them. So, but there is a still challenge because the servers of most of those AIs, they are not in our country. They are just in US or Russia or somewhere. So that's a big challenge, but still there are both now currently WHO has developed a guideline and also there are international guidelines. Thank you.
Okay, thank you. The sixth question reads, if a colleague falsifies data in a study, what is your ethical obligation as a health professional?
That's what I was saying. We have to act as a whistleblowers. And that's very challenging sometimes to stand out against your colleagues, especially if it's going to put both the patient, and also the science. It's going to jeopardize the science. Our obligation is for our patients and for the science. Yes, we have obligation for our friends, for our colleagues, but our primary, as a physician, our primary obligation is for the science. So we have to act as a whistleblowers. And we have to report. And this is very much challenging. And this is actually a lot of happening a lot in our setting. Currently, openly, actually this week also, I'm sort of sorting out those things. Physicians, most physicians, you have the data, and most of the publication in Ethiopian institution are being done not by physicians. Those clinical publications are being done by public health practitioners. And on doing so, some of them, they may not even include any physician. So the first thing here is they may introduce some mistake. The second thing is they are taking most of those data unethically without the consent of the person who has collected them. And the other thing is most of the time, because they miss some of the informations, also the skill, they tend to falsify them.
Okay, thank you very much. The seventh question reads, do you need consent of a patient for surgically removed specimen, which is going to be discarded?
Yes, you need a consent to be used. This is very much important, actually. Well, this is a recent actually update in the ethical guideline, also in 2005, 2012, the revision of the health study has to include this. One of the things is who owns those samples? Is the patient or the hospital? Because some of those samples, you don't know where they are going to end up and what their importance. A simplest example I will tell you is that anybody who knows about Henry Talak or the HeLa cell. This is a very interesting story. The HeLa cell was found, actually, this is a patient with cervical cancer in 1950s in Johns Hopkins Hospital. The world was, or researchers were looking for a cell, human cell, which can divide. And they were trying a lot of scientific experiments. No. And a pathologist called Greg, once he has a cervical CA patient, he took this sample, he cultured it, and continued to produce. And the HeLa cell is currently available in most of the European and the US and any advanced medical institution, the HeLa cell. And this is from Henrietta Lack. And the point is, the woman has died from cervical cancer. Her cell was being used for most of the intracellular studies, from diabetic, polio, and so on. The diabetic medicine and so on was just insulin was produced from her cell. And pharmaceutical company has just earned billions from these cells. But the woman, she didn't even have a health insurance. She died. So in 2050, there was a court situation. Actually, her descendants, they found out that their mom cell was being used in the pharmaceutical industry. So for the scientific world, it has brought the question. Actually, there are a lot of such examples. This is a simple cervical cancer sample. You think you can discard it? Yes. But if you use it, it may come out of it. And the most important is who owns it. So yes, you need consent. And usually the consent actually will be taken for specific experiments. When you take a consent, for example, you take a sample, you say you are going to test it for hepatitis. You don't test with that sample for other disease, for malaria on. So no, the consent has to be specific. Thank you.
Thank you very much. The eighth question, so one of our attendees was planning to conduct a research in refugee setting in Ethiopia, and he had adopted a tool that had already been validated in the Ethiopian context. However, the ethics team raised concerns about using it due to the vulnerability of the refugee population. So his question is, if the tool has been validated in Ethiopia, why might it still not be considered suitable for refugees? And what steps can he take to address these concerns?
Well, as I have said, you don't really exclude people because they are vulnerable. The thing is, when we say vulnerable people for Ethiopia, these are prisoners, pregnant women, children, and military people, and people incarcerated in general. And it may include also refugees because they are in a camp. And because they are so poor, the notion was you can really easily manipulate the No. But the issue is, does the research benefit for the refugee, for that vulnerable group, for that mentally disabled people, for that children? If there is no other way to generate the study evidence except to do a research on such population, there is no way out. The study has to be done. That's how actually the ethical review committee sees. You can't do a research on men and give that medicine for women. If there is a chance, you have to do it for women. You can't do. One of the issue with us was one of the medicine we have been testing, pregnancy was being excluded. So at the end of the day, we're thinking that, well, what about in the future? We don't have medicine for pregnant women because we're not testing it on them. The most important thing is we have to really prove the safety of that drug on the woman. And we have to make sure that there is no other way, there is no other alternative treatment for that vulnerable population. So I think it depends on the ethical committee, but from the researcher side, what you need to advocate is the study results will benefit for those populations. If it benefits for those populations, that's the most important thing. Thank you.
Okay, thank you very much. The next question is, what are the elements to fulfill in research ethics, especially concerning health research ethics? Okay.
Well, that's what I was explaining, the 7 The first thing is it has scientific value. That means for human being, that the results, the outcome, whether negative or positive, help for human value. And the next is social. Is this socially acceptable? And the other thing, methodologically, and the risk benefits, and it has to pass through IRB. And these are just some of the ethical frameworks to say research is ethical or unethical.
Okay, thank you very much. We have only a few questions remaining. So the 10th question reads, is a research that involves genomic studies equally ethical for human genome and microorganism genome study?
Yeah, the issue is, yes, it differs in Ethiopian setting also very much, especially for the genomic study. The most important thing is your study, the ethical approval or the consent form has to be specific. What type of genomic study are you going to do? And it has to be restricted to that. Simple, just to give you a caveat here, you can take, currently you can map the whole genome of an individual, what's happening in the West, and after mapping that genome, you can identify the risk, whether he has a risk of diabetic, whether he has risk of cancer, and so on. And pharmaceutical company or insurance company, if they have the access for this, they can determine actually your insurance premium. So because of those factors and others, the genomic study, actually the ethical review committee is so rigorous when it comes to the human being. For microorganisms, currently also it's changing. And in Ethiopian setting, especially if it is microorganisms, you have to go to the biomedical institution for the material transfer and so on, because every microorganism genome has to be reserved in the country. So the research, the genomic studies, they are more rigorous because of the risk they have, or actually the vulnerability of the participants, especially when it comes to human.
Okay, thank you very much. The 11th question reads, is it unethical to pay allowances and or compensations for study participants?
No, it's not unethical. It is actually say that because when you say the risk, protect the individual from risk, you have to protect the participant from risk of physical risk, mental risk, and also economical risks. So those patients, or those participants, sorry, when they come to the research, they are spending some of their time. They may be paying for their transport and so on. So there is, the balance will be usually maybe difficult, but they have to be compensated for the time they have lost and also the expense they have lost. But that money must not be so big to block their judgment and force them to enter to the study. That's, yeah.
Okay, thank you very much.
Also, actually, in the other side, when you have control, especially for clinical study, the participants for the experiment, either for the placebo or for some experimental drug, they will enter to the study knowing that there may be harm. And those people are compensated very much, actually.
Okay, thank you very much. So the last question we have is, you mentioned earlier that the patient or participant should know everything. So if then, what do you think about double-blind type of study?
Double-blind is not about that's about medicine you give them. It's not about the study. They have to know, and they have to tell them. We did, for example, we have been doing the double-blind study on STH. So when we give for the students the medicine, one of there was 3 arm. One is ivermectin plus albendazole, and placebo. So you tell them that we are going to give 3 types of we are using 3 types of medicine, or 2 types of medicine. One is the actual medicine with chemical. The other is it doesn't have medicine. We don't know in which group you are. So you tell him up front that this is, you don't know in which group you are. I don't know in which group you are. So the tablets or the medicines are packaged in the same. So you end up like that. So when we say, yes, you don't know the medicine, but you have to give him all the info, the other information. Thank you.
Okay. Thank you very much. So these are the questions we've had so far. You've addressed them in a comprehensive and patient manner. So thank you very much, Prof. So having said that, we'll directly proceed to the quiz. We'll share the quiz here as well as on our dedicated Telegram group. So we'll give our attendees 10 minutes to attempt the quiz. After that, we'll recuperate and attempt it together with Professor.
I just like to address the final question. He's in doing observational study. Do we have to report unfavorable practice we detected to the responsible body? Yes. And the thing is, if we are doing a retrospective study of doing observational study, the goal of the study is to correct whatever we are doing, or just also to recommend a procedure. So it has to be reported because people has to learn from that, and it has to be published, both negative and positive outcomes.
Prof, another interesting question in the chat section. Maybe while we're waiting for them, we can address it as well. It reads, in clinical care, for example, if there is no time to explain and to save life, what can caregivers do?
Well, in emergency, that's a different thing. That's has nothing to do with the research. If the clinical care, there are certain if it's an emergency condition, usually as a physician, the Ethiopia scenario, if 3 physicians agree on the intervention, I think the procedure can be done, especially with the social workers. And that's one physician alone will not decide. That's the Ethiopian guideline, clinical care line. And if the patient is comatose and so on, either surrogate decision maker has to come on. But in emergency condition, there are certain exceptions.
Prof, another question that actually popped out right now, it says, is there any guidance for health systems research, ethical oversight, or learning healthcare systems in Ethiopian context, since the line to separate research and practice is blurred?
That's a recent development. One of the challenge with health system, these are usually categorized on your operational researches. So it depends. When any research needs RB has to be evaluated. But the most important thing here is if it is an operational research, institution has the rights to decide whether it can be published or not. And there is a special guidance about it. And practically can get that guidance from the WHO TDR website, sorted. There is an interesting examples there on health system learning and health system researches.
Okay, thank you.
WHO TDR sorted training, operational research. Clinical trial physician can be PI, it can be, but clinical trials, one of the, from the Nuremberg trial, actually, one of the ethical code is any clinical trial, it has to be done by an able person or an expert in the subject matter. That's the most important thing. But yeah, researchers currently, they are collaborating. And So non-physician can be, and especially on this, the biomedical researches, that's possible. In multi-center clinical trial, the guideline we use is first, it has to be, it has to get ethical approval anywhere or everywhere actually, even in your institution and also to national level also, because one of the things with the good clinical practice is research which has been done anywhere. If you follow the guideline of good clinical practice, it will be acceptable anywhere in the world. Because when you start to do the research, clinical trial, it will be registered globally in the website. There is clinicaltrial.com from the US side. So it will be registered. So every people, experts on that world are following you. And you are following this, the international guideline in addition to your country guideline. So because of that, at the end of the day, when you finish the study, that study outcome is acceptable actually globally if you pass through all those international approvals.
Nice, Prof. Thank you. One interesting question, actually, it's a final question. We'll take it as a final one. The question reads, some laboratory information containing genetic information sometimes is sent to abroad for further diagnosis. What do you say from ethical perspective?
So እነዚህ የላብራቶሪ ኢንፎርሜሽኖች there is a rigorous procedure የባዮ ዳይቨርሲቲ ኢንስቲትዩሽን የሚባል ኢትዮጵያ ውስጥ በእነሱ አፕሩቫል ነው የሚወጣው። So they have both for biological samples and non-biological samples guidelines አላቸው. And so the most important information is because the biodiversity institution ከመጀመሪያው ጀምሮ ሲቋቋም ኢትዮጵያን ባዮዳይቨርሲቲ ሬጂስተር ማድረግ ነው። both እንግዲህ healthy every biodiversity ማለት ነው, whether it is disease or whatever. So usually those things has to pass through the biodiversity, and there has to be material transfer agreements to be signed between those institutions. And on those samples being sent, there has to be specific thing to be done. So this is based on the consent or on from the primary protocol. When the protocol is developed, if you say that this sample, this tissue sample, we are going to screen it for certain cancer or certain chemicals, that's the end of the story. That is what is going to be tested. So that's following that, most institutions throughout the world, they keep those samples and data for 10 to 15 years. And if they are going to do anything beyond what's agreed in the primary research protocol, there is a need for a new consent. And that can be mostly from the participants or from the institution. Thank you.
Okay, thank you very much, Professor.
Thank you.
So we have 225 responses, and we're no longer accepting responses since the allocated time is over. So I'll share my screen with you, Professor, and we can go over the questions together. Okay, so the first question is, what is the primary ethical justification for health-related research involving humans? The first choice is financial gain, B is scientific and social value, C is institutional prestige, and D is ease of conducting research.
So most of the participants, 97.8%, answered the right question, the right answer, scientific and social value. That's the primary, actually, ethical justification for. So you can go to the next, yeah.
Okay, thank you very much. The second question reads, what is the risk of over-recruiting marginalized groups in research? The first choice reads, simplifying logistics. B is overburdening disadvantaged populations. C is reducing research costs. And D is strengthening community trust.
So this question has to do also actually with the question one of our participant has raised, recruiting participants from the refugee camp and so on, because you get them easy from one place. So the first thing is the disadvantage of this is just from the scientific perspective, you may say, oh, it will overrepresent a certain group, so it will not be generalized. But when you look at it, you look it from the patient, from the participant perspective, and from the participant perspective, we are overburdening those participants. Unnecessary burden. Thank you.
Okay, thank you very much. The third question reads, what obligation do sponsors have after trial completion? A reads to publish findings in high impact journals. B is to make successful interventions available to participants. C is to prioritize new project funding. And D reads to recruit the same participants for follow-up studies.
So any research actually in any country, when it is being done, one thing which the IRB or the National Ethical Committee will make sure is, at the end of the day, if there is a favorable outcome or when you develop the drug, it has to be accessible for those population. That's the most important thing. And this was breached in a certain time. A typical example was the fluconazole study in West Africa during the HIV era for toxoplasmosis. Pfizer, they did the study and they found fluconazole is a better treatment at that time, is superior. But the fluconazole was very much expensive. And following the finding, they took the drug and those people didn't get the drug. So that is not okay. So the advantage of having a research being implemented in your country is actually the country or that population has the right to get that medicine first when if it's going to come out. This was one of the issue also, typical example during the COVID time, one mistake which the WHO has done, actually a mistake. If you remember, the WHO general at that time said that Africa are not a guinea pig. So we don't test. So most of 97% of COVID studies, 97% of COVID studies were being done in the US and the West. So when first the COVID vaccine was developed, because the test was done, the study was done in US and Europe, they were the first beneficiaries. If it was done in Africa, those countries has actually the benefit to get that. Recently, you may have heard about the malaria vaccine. Malawi, Kenya, and the third country, I think Uganda, malaria vaccine. Well, WHO has approved it. It has certain prevention, especially for children's. And they are the one now first using the vaccine with a minimum price and for free because the test was done there.
Okay, thank you very much. The last question reads, which principle guides research ethical committee decision making? A is convenience, B is ethical integrity and public accountability, C is rapid approval process, and D is community popularity of researchers.
So here, the ethical committee, usually we say that it's an independent review board. So usually it is organized into, well, this an even number, 7, 9 or something, and it has to include both from the scientific community, gender, and also from the society. But at the end of the day, the IRB is focused on protection of the participant rights and looking into the validity of the study, whether the study is going to generate an important information for a human being. So the focus, the guiding principle is just its ethical integrity and public accountability is the most important. Thank you.
Okay, Thank you very much, Professor. So these are all the questions that we had for the quiz. So back to you, Dr. Khalid.
Thank you. Thank you, Dr. Tadail. Thank you, Prof, so much for the engaging presentation. We have a large number of participants and very active. So with this, I would like to conclude today's session. If there is anything you'd like to say, Prof, I can give you the floor for one last time, then we can wrap up today's session.
Thank you very much. I think there are some questions left over. I hope you can text me or just you can use my email, and I will be happy to address those questions. I'll share again my email, and also actually I can share my Telegram number. That will be better. So there are very critical questions which from Afar and so on. Yeah. So yeah. So I think thank you for giving me this chance also at Yetena Weg, and I hope we'll meet in the future. Thank you.